Yes, he's there.
There he is. Hello, Tomoki.
Hello.
Hi, welcome.
Good morning.
Good evening. Thank you for your presentation. So, I have a couple of questions here. Perhaps I can start with Dr. Kosho. So, we've heard your presentation, so one of the questions that we have is for a condition like musculocontractural EDS, which is caused by an enzyme defect. Are you doing, or are you aware of any research being done on developing therapies for this condition that really targets
Thank you. Theoretically, enzyme replacement therapy, or can you hear me?
Yes.
Okay.
Yes.
So, theoretically, enzyme replacement therapy or gene therapy would be good, but we are trying some experiment, but now we can't complete any experiments, even in mouse model.
Okay, thank you very much. There is also a question for my sister regarding all the pain issues, and I think it's a really good question, actually. One that we are also thinking about is why do some people with joint hypermobility develop pain and why others do not? And perhaps from your experience with osteoarthritis, is that something that you can
So it's a question that is relevant to other diseases also. So for example, in osteoarthritis, people can have a really very damaged knee, say, and not have much pain. And then there are people with barely any knee damage who have a lot of pain. So that's just something that happens in the general population. So that wouldn't be different in people who have a form of EDS. And that is determined by very many different factors, such as a lot of other genetic factors. So there are quite a lot of single nuclear polymorphisms that have been described that are either protective against chronic pain or that where people have more chronic pain. So that's something that's just one explanation. I think that there are probably very many other explanations, but as long as we do not really drill down into all the specific mechanisms in all the very specific types of EDS, we cannot really answer that question.
Can I ask a follow-up question? I'm intrigued about the pain sensitization mechanism. Should we be, as a pediatric physician, seeing patients before they're developing the chronic pain, which tends to happen towards adolescence? Should we be doing a better job at preventing pain?
I think that's a very, thank you for bringing that up. So that's why it would be so important to do pediatric studies. Again, I will give you the example of osteoarthritis in that it's only in the last 10, 15 years that people have done very large cohorts of people who develop knee osteoarthritis, for example, and doing now very large studies with quantitative sensory testing in people before they have chronic pain in the knee, say. And the biggest predictor, so you can look at depression, anxiety, sleep problems, and you can tap the knee and see if there's a hypersensitivity. And if you control for everything else, that knee hypersensitivity is the biggest predictor for knee pain 2 years down the line. So yes, I think that would be fascinating, because then if there's a local sensitivity in the skin And then all the long-term consequences are all the changes in the brain that happen throughout when the child then becomes an adult and accumulate. If one can intervene maybe early, then one can prevent or reverse these changes. That's what I'm hoping that could happen. Mm-hmm.
That'd be great. Thank you.
Okay, thank you. Then a question perhaps to Dr. Demirdas. So I'm gonna introduce it a bit more, but we have seen that if you look at all the different types of EDS, there's a lot of clinical overlap between the different types, and now with all the genetic testing, the panel testing, often people will get a report where it says that they have variants in different genes, in different EDS-related genes, variants of unknown significance, or difficult to interpret variants, but I can imagine it's very confusing for patients and even for physicians. So the question is it possible to have more than one type of EDS? And it's a question we often get.
So it's not impossible. We don't see it often. It's quite rare. And we know for genetic diseases that there are people who do have two. So we also, for example, well, I can't give details, but we have one patient who has two types, but that's due to a deletion where the two genes are very close to each other. So yes, but it's very rare.
Yeah, theoretically it's possible, but...
Exactly, we see it not very often. Like the top of my head, I know one patient, so that says something.
We don't have any patient that is molecularly diagnosed with more than one type. I think that to your point of patients coming with features that may overlap different types, there were two concepts that I didn't go into the talk, which are variability and penetrance. And penetrance refers to whether you carry a variant in a gene that is usually associated with disease, but diseases with incomplete penetrance, you may carry the variant and not present the same expression. And then variability would talk about the severity that different individuals have. So we don't have molecularly confirmed with more than one. I think that the statistical chances of having two genetic conditions off the connective tissue in the same individual are low. However, the symptoms may overlap because of the manifestations, and they may be different between their parent and the child, or in different generations.
Okay.
Fransiska?
Yes.
I have a patient who has both classical type and vascular type. He is a kid, and her mother has classical EDS, and her father has vascular EDS. And the parents met at the EDS Society in Japan. So,
Okay.
but
Yeah.
it is naturally it is a very rare situation. But in some situation, it is very sometimes reasonable.
Yeah.
And he is a very happy boy.
Very happy boy. Good, good. That's hopeful. Okay, then I have a question for Roberto. And this is a question coming from a person with a phenotype of hypermobile EDS. This person had panel testing. And so there was one VUS identified in a gene that is associated with autosomal recessive type of EDS. This here was in the kyphoscoliotic type, but it could be any autosomal recessive type of EDS, but just one variant of unknown significance. And so the question is, could these heterozygous variants still cause disruption of collagen synthesis, despite despite not presenting as that specific type of EDS? So is there a role for these variants in the phenotype of hypermobile EDS, and are there actually any studies being done on this?
So I think that there's two elements to that question. One is when we find only one variant in a recessive condition, if the patient meets the criteria for that recessive condition, we do due diligence to look for the other variant. And sometimes that due diligence includes the lesion duplication testing that is not included in all panels. That may include doing research sequencing of the regulatory regions. However, in this individual and in your question, many don't have the criteria for the specific recessive disorder. And the question would be, would carrier status for a recessive disorder lead to some of the features of hypermobility? I think it's an active topic of research. For enzymatic defects, we don't seem to have that as much. In the kyphoscoliotic, we would presume that the gene that is functioning would be producing enough enzyme to meet the role. I think that for structural collagens, for the dominant ones, is clearer than the recessive ones. The jury's out. I think Tenassenex, the manifestations of carriers for Tenassenex variants are being studied, and that can have a role. And other structural proteins may have a higher role, but we haven't found them in the studies of the hypermobile population. I think that if they were there, the genetic studies that have been done using whole genome sequencing would have identified a higher proportion. So I don't think that's where we're missing the clue.
Okay, thank you. And perhaps also, we had a lot of questions about the VUSs and the molecular testing and so on. So there is a person who is asking, there are a lot of numerous small studies, genetic studies, but wouldn't it be easier to determine pathogenicity of VUSs if there was one database combining all the information on heritable connective tissue disorders? Could you explain how that works?
So sure, there is international effort, and laboratories submit the variants that they find to different repositories. ClinVar is one of those repositories, and you look, when you are interpreting the variant, you do look to see if the variant has been reported before, how has it been reported by the given lab, and depending on the information, the lab may give some clinical clues about what that individual that has previously been identified with the variant had. I do think that we could do a better effort as a society to perhaps enhance databases of for the genes of interest and to collaborate, because right now the efforts are geared towards experts. We have the ability to communicate with one another, and there were for a number of years databases that were supposed to bring in all that information, but it takes time. The sharing of information, I think it's becoming more global. And so we have international databases, not specifically of connective tissue, but of genomic data that are leading to a better interpretation of variants.
Okay, thank you.
And
sorry.
may I add to that? Because we also, of course, have now gene matcher and variant matcher. So if we find variants that we do believe might play a role, we, as geneticists, can also enter it to variant matcher. So then it's like a dating site. I have this variant, do you also have it? Oh yes, let's check if this is something or not.
Absolutely.
Then there is a question on the last talk. How can we convince healthcare providers who are already stretched thin to get involved in research, if that is the only way to reach many of these rare EDS patients?
Yes, that is a big problem. And as I said, I think the EDS Society plays a very good role for EDS in making sure that there is more knowledge about the diseases, because to find experts everywhere is not so easy. Like I said, funding is not broad, so to get people to actually work scientifically on EDS, you need a financial incentive to also keep it going. So you might have some money for now, but not for later on. People think about this when they make career decisions, which is logical. But for this reason, we have to make sure that those physicians who do contact patients, who have them within their vicinity, can find information, and those few experts that are out there should be able to be reached. And I think this is happening. I think we are all getting emails and phone calls from fellow clinicians throughout the world when it comes to EDS.
Can I make a...
Yes, definitely.
I feel that there's somewhat of a disconnect between funding for research and funding for clinical services. And I think that in the area of translational genomics, there can be a better role in which grants should open to the possibility of somebody doing clinical training in delivering services, as well as research training as part of that. And at present, I find that there's one or the other. It's hard to apply to something that will allow you to do both. And that's something that could work to increase on both fronts.
Okay, I think we're going to end this here. So I would like to thank all the speakers present here and in Japan. Thank you, Tomoki, for joining us also. And I'm going to end this session here and invite Lara to close the meeting.
Thank you.